First initiative that Mason Institute has had with the Global Health Academy, and we're very pleased that that started, and want to look forward to a fruitful relationship in the future. And most importantly, I'm delighted to introduce Jennifer Prah Ruger from the University of Pennsylvania, international scholar. Doesn't need any introduction from me, but it's fantastic that she joins us today to talk about global health justice and governance, and looking both from a theoretical and empirical perspective at health equalities and inequalities across different countries. Jennifer.
Thank you. Thank you so much for having me. I wanted to, I'm delighted to be here. I wanted to first thank Graham, of course, and Elizabeth, and also Sue and Lisa from the Global Health Academy for hosting my talk today. I'm going to talk about a series of projects that I've been working on for several years, both theoretical and empirical, as Graham mentioned. I'm bringing them together in a book with the same title as my talk, Global Health Justice and Governance, with the Oxford University Press, that I've been working on with the Guggenheim Fellowship from the Guggenheim Foundation in the US. So just by way of outline, I'm going to start by talking about a little bit of theoretical work in equality and inequality. Then I'm going to show you some empirical work on health disparities among countries and indicators associated with health inequalities. I'll then come back to theory and talk about alternative paradigms and health equity and moral responsibility. And then I'll move to governance issues, discuss why I think justice matters for governance, and then discuss duties and responsibilities of global and state actors. So first, by way of theory, equality can be theoretically constructed or conceptually constructed in several different ways. And I'm going to talk about two today. The first is attainment equality, and the second is shortfall equality. And I'm going to be moving in the shortfall equality or shortfall inequality direction with my work. So attainment equality is equal absolute levels of achievement. So if we're comparing two societies, Society 1 and Society 2, attainment equality would be satisfied if the life expectancy for both societies would be, say, 40 years. That would be attainment equality, and that would be satisfying that, that requirement. Shortfall equality, however, is equal use of respective potentials. And so what we're interested in when we're looking at shortfall equality is the shortfall, or the difference, from a desired value or a target level. So for example, we're looking at some sort of, and the statistics that I'm going to show you will identify at the target level. Say we really want the objective to be the life expectancy of the best off country in the world, say Japan, for example, which is always topping the charts on our health statistics. Then that's the objective. It may also be that within a society, different societies have different potential maximum. So one maybe has 80 and the other has 75, and choose different societies. And so what we're interested from a shortfall perspective is the difference where that society is, or where that person is, relative to what the potential is, or what they could possibly be achieving. And so why is this important? Well, it's important because the shortfall equality measure takes into account potential, what's possible. And I'll show you some of the empirical work to demonstrate why we think that that's something of interest. And so from a global health perspective, the goal is to reduce the shortfall inequality, and therefore reducing the gap between the possible maximum and actual achievement to fully realize a given either individual or group's potential. And so this kind of a framework for equality can be used either for individuals or for groups. And I'm going to show you some work on looking at groups, and the group here will be the nation, different countries. So from a shortfall equality perspective, my colleague Hak-Chu Kim, who actually was a former graduate student of mine, who's now a professor in South Korea, we use the World Development Indicators, which is the World Bank's data set of indicators for the world. and these are at the national level. And there's lots of issues with international data, and there's also all sorts of quibbling that can be done about these kinds of statistics. So we thought the World Development Indicators is one of the most reliable and valid. So, and it provides, the other thing that's nice about this data set is it provides both health and social indicators, but also economic and other and health system and public health indicators, which we were interested in. And so from a shortfall inequality perspective, what we did a cluster analysis, and we were basically trying to understand if countries fell into different groups in terms of their level of health. And group 1, which is the darker green in this slide, is the better off group of countries. So these countries have, and this is under 5 mortality, have better under 5 mortality rates than countries in the worst off group, which are the lighter green. And we were interested in this, and we wanted to stratify and think, why would you stratify and sort of disaggregate this data and then try to cluster it again, as we were interested in trying to understand, again, what's possible. What in terms of health, and I'm going to show you a couple of different types of health statistics. What's the sort of maximum that's possible? Assuming that there are really no major biological or genetic differences among people throughout the world, then we would think that, you know, what's possible for a group of countries that cluster around the top, the potential or the maximum, could be possible for all countries. Maybe. And so from an inequality perspective, we're going to try to understand what the difference is, what that gap is, and then what's associated with that gap. So here we see a geographic distribution. The countries that are darker green are the better off countries with a pretty low under 5 mortality rate of about 16 per 1,000 live births. And the worse off countries are the light green, and we see a major concentration that we see in Africa. And those countries have about 165 deaths under 5 per 1,000 live births. So I'm going to show you a series of statistics that are interesting, were interesting to us because we saw very similar trends when we looked at different, we thought, well, maybe it's just under 5 mortality or infant mortality or adult mortality, male, female. We actually saw similar trends among these different mortality measures. We did the same analysis with adult male mortality, and the dark blue is the better off group of countries that have, and this is premature mortality before age 65, have an average of 125 deaths per 1,000 male adults, whereas in the worst off group, which is the light blue, again the lighter color, it's about 427. So not quite half of the population is dying prematurely. So that's a big difference. In female mortality, we did the same analysis. The dark red is the better off group again. This is premature mortality, and has a lower mortality rate for women. And the worst off group is the yellow group of countries. Again, you see a strong clustering in Africa and especially here in southern Africa. We have, of the African continent, we have about 420 deaths per 1,000 individuals. So again, you know, about not quite half of the population. So big differences between groups of countries, and we see the middle group is interesting to us in reference to, again, the better off group, our reference, our potential group. And they also have, as you see, a shortfall. But the biggest shortfall is the worst off countries. Okay. So we were also interested in understanding whether this changed over time or not, sort of what was happening with particularly the gap. Because from a shortfall and equality perspective, we're interested in the gap between groups of countries. So if we look, and this is also a benefit of using the World Development Indicators, because we could look from several decades over time. And again, if there's no major biological or genetic differences among groups of people and countries, one would think that there would be the possibility for convergence So if the potential is to have, you know, these lower mortality rates on these different indicators over time, and certainly with major expenditures in global health and other domestic health, we might see a convergence or a reduction of the gap. So we were interested in knowing whether that was occurring or not. And so the orange line is the worst off group, that worst off group of countries, and this is the under 5 mortality data. And the blue dotted line with the squares is the better off group of countries. And what we see is we do see changes in mortality over time, and we see for the first several decades of this time series trend, we do see somewhat of, you know, some reductions in the gap, or at least a getting closer. But then, you know, not as much between 1990 and 2000, and then a leveling off, and there's still, what we were interested in, we have this data up to 2009, still a large gap between these countries. Okay, saw the same, we did the same analysis for the adult male data, and again, the orange line is the worst off group of countries, and then the blue dotted line with the squares is the better off group of countries. And again, we see a gap the whole way through in these for these decades. We see actually an increase in the gap a little bit between 1990 and 2000, a leveling off, but still a significant gap in 2009. And then lastly, we did the female mortality data, and this actually was quite revealing to us. We looked over time, we actually saw a closer margin in terms of, again, the worst off group is the of countries is the orange line, and the better off group of countries is the blue dotted line with the squares. We see actually a closer margin between the two lower groups in terms of female mortality, and actually even getting closer and closer. Still a big gap between those two groups of countries and the better off group up to 1990, but then we see a reversal actually from 1990 to 2000, which is not just, as we saw in these other graphs, where you know, mortality is being reduced by all the groups, but the gap's not being closed, and we see that for the most part with the adult male mortality, except for 1990 to 2000, we actually see for adult female mortality an increase in the gap. So this is a cause, we think, for concern from a moral perspective. This is just information about how the rate of change of mortality, and the better off group is the blue bar, and the worse off group is the green bars. And this basically is telling us, we were interested in how efficiently or how well these countries were doing in terms of reducing mortality. Again, to the extent that there are no major differences in countries in terms of their population per se, because it may be harder, right, if there were major differences, but that these are amenable to social and economic variables, then we might see similar rates. But we see that the better off countries, who are already better off, are doing a better job of reducing their mortality, and over time, consistently, and consistently better than the worse off groups. This is the under 5 mortality. We see with the adult male mortality, again, the blue bar is the better off group of countries, the green bar is the worse off group of countries. And we see here not just that the better off group of countries is doing better at reducing its mortality, but that between 1990 and 2000 and 2000 and 2009, 1990 and 2000, which we actually saw that uptick in the previous slide, they actually aren't reducing their mortality, they're actually increasing it. This is the worst off group. And again, we see with the female mortality, we actually saw that, again, the blue bar is the better off, these better off health countries, and the green bar is the worse off health countries. And we see that female mortality, especially between 1990 and 2000, we see an increase in mortality as opposed to a decrease for the worse off countries, but not as much between 2000 and 2009. So this is really a picture of the world and what's going on in terms of these global health inequalities. And we just looked at a few indicators. You could certainly look at other kinds of indicators of health. These are the ones that we looked at. So what's associated with these inequalities? And this helps us understand whether from a governance or a policy perspective there's anything that can be done about addressing them to the extent that we think that there's a problem. And I'm going to talk theoretically about why there might be a moral problem with this difference. What might be morally problematic about it. So, and I wanted to make sure that it's clear that these are associated factors, these are not causal factors. So these are social and economic indicators that were in the World Development Indicators database that we found were related to and put countries at risk of being in the worst off health group. So extreme poverty. So those countries in all three of those indicators that were in the worst off health group had more of their population that lived in extreme poverty. And extreme poverty here is measured in terms of people who live on less than $1 a day from the International Purchasing Power Parity statistic. And those countries that were in the worst off health category had, in many cases, up to 50% of their population living on less than $1 a day. So half of the population is living in extreme poverty. So that's a very challenging social, economic, structural factor. And extreme poverty is where much of the work in global justice is focused on. So a number of scholars and also policy analysts are working in the area of global justice, which is trying to understand principles of justice for the global community broadly. And the Millennium Development Goals are one part of this. International human rights are another part of this. But folks that are working in this are, many of them are focused particularly on extreme poverty. Some people are arguing that extreme poverty is a cause of the international system, the global governance system, and that wealthy countries like my own country, the United States, who support an international system that affects poverty, are therefore morally responsible for addressing it because they've had a hand in creating it. So some of the global justice literature is in that direction. I won't go through all of it, but other issues that are other indicators that are related: inflation and currency instability. Think of like Zimbabwe, where things change very rapidly, right? In terms of what your currency is worth. Very difficult to establish a structure, right, to address health needs and other kinds of social needs in an environment where there's rapid and hyper currency inflation and instability. Percentage of GDP in trade, that's sort of a marker for being connected to the global economy. Higher percentage of individuals living in rural areas, we see major differences. So the worst off countries health-wise also have much larger percent of their population living in rural areas as opposed to urban areas. And this is, again, somewhat of an indicator of access to the infrastructures in a society that may help in addressing health and other needs. Communication, information technology, that's another measure of connectedness. And then much higher levels of female illiteracy in these countries. We know from a number of social scientific studies that women's literacy is related to health, both her own health, a woman's health, but also the health of her family. So, and then we are very interested in looking at indicators of the public health system and the healthcare system that were associated with these associations, not causal, these health inequalities. And sure enough, for the healthcare system, those countries that were in the worst off group had lower per capita spending on health, in many cases about tenfold, on average about $10 per person. $10 per person as opposed to over 100. Lower per capita outpatient visits. Now there are lots of quibbling that can occur with these particular indicators, but they're in some way a sense of the infrastructure that's available to people in terms of the health system. Lower per capita hospital beds, and then lower physicians and nurses per capita. There are also lower immunization rates, lower rates of access to improved water, and lower rates of access to sanitation. In the worst off countries, those rates were about 40%, or less than 50% of the population has access to these basic public health services. So the infrastructure, the whole infrastructure that's in place in these settings is very different from the infrastructure that's in place in the countries that are doing better in terms of health. So what does this picture, this empirical picture, look like from different perspectives? And if one could argue that the picture is the picture, those are the description of what's going on. And the question is, the paradigm that one adopts or puts forward, or either implicitly or explicitly in viewing the world or global health in particular, has a lot to do with, or has something to do with both why things are the way they are, and also why things might be advanced in terms of an alternative governance or policy structure. I think that underlying values and underlying principles have something to do with the way societies are set up, either globally, a global society, or at the national level, then the particular paradigm that one adopts tells us about what this picture looks like. So from a neoliberal or sort of economic perspective that's focused on income and wealth, global health inequalities may not be problematic. They would only be problematic, possibly, if they were related to income or wealth. So if what we're after is for countries to grow economically, or for GDP per capita or GNP per capita to be robust or to be advancing, and these kinds of measures of the success of a country or globally, then the health indicators and the differences among them may or may not be problematic from a moral perspective, a theoretical perspective, unless they're related to income and wealth. And there are arguments that are made that these poor health is bad for economic growth, or bad for income at the household level. From a utilitarian perspective, we're looking at pleasure or desires or utilities, and sort of social welfare. And to the extent that health is an argument in a welfare function or utilities, then it's important, but if not, it's really, in and of itself, there's no reason to think that it has some sort of special importance. In terms of libertarianism, or focus on liberties or property rights, or what we call negative rights, civil and political rights, health inequalities may or may not be important depending on whether or not they're related to these kinds of procedures. From a Rawlsian perspective at the country level, both sort of within a society, primary goods are the focus, and the Society of States, the Law of Peoples, which is looking at basically ethics for foreign policy. The question is whether health inequalities may or may not be important. Of course, there's a duty for aid in that kind of a framework, but those particular health inequalities may or may not trigger that. From a cosmopolitan perspective, which is focused on human rights, these kinds of inequalities could be captured in a human rights perspective. They certainly could, and there is a right to health. Those are on the positive rights side. The positive rights tend to not be as well supported internationally or domestically in many settings as the negative rights. So it would depend on the support for on those positive rights. And from a nationalist perspective, which is a perspective within the global justice literature, for example, it's not clear that there are global duties or global responsibilities for those inequalities. They may simply be the responsibilities of those particular countries. So really not a global problem, because it's a national problem. And those inequalities are the responsibility of those particular countries. And whether they want to address them or not is really up to that particular country. So the approach that I'm focused on is one that takes human flourishing as the end goal or objective. It focuses on human lives and substantive freedoms I'm going to talk a little bit more about that in a minute. And from that perspective, which in the work that I've been doing on provincial globalism and shared health governance, these inequalities are problematic. And I'll talk to you a little bit more in a minute about why, from a moral perspective, from a theoretical perspective. Okay, so in terms of health equity and moral responsibility, why are these health inequalities that I just spent all this time showing you data about, why are they problematic and what's going on here? And I would argue that from this perspective, health inequalities represent failures to discharge global and domestic obligations, which are positive duties, of global health equity. Why? Because health and human flourishing is a morally central aim that's shared by all persons on the planet. All persons on the globe, by virtue of their humanity and being human itself, our common humanity confers moral status. So those statistics represent people, and people whose health is failing, and who are, as we just saw, extremely far in terms of shortfall, inequality from what's possible globally. So the proper end of global social and political activity is health and human flourishing. And some of the articles I've written have drilled down in terms of those particular arguments. Health is a morally salient human characteristic that warrants respect and requires protection and promotion, and meeting health needs is required to flourish. So health inequalities are reduced, as we know, through social organization and collective action, whether it be globally or domestically. And so this is at the global and the domestic level, and so this requires reforms to the global and domestic health governance to address them. So that's a sort of very short version, and so in terms of tackling these health inequalities, health inequalities reflect broader social, political, and economic environments in which people live, and countries are operating within a global environment. They aren't in isolation in this globalized world, as we saw from the statistics about the interconnectedness of countries with the global economy and the global structures. So global health inequalities are not reduced to the market mechanism alone. Government and public policy is required, and they're not reduced through the health sector alone. International and national responses to health inequalities need to be rooted in ethical values about health. As I was saying, with the different paradigms, the question is whether or not health is an important value in those perspectives, and whether it's important intrinsically, instrumentally, or both, to warrant a focus from a policy or governance perspective on health and addressing health inequalities. And so treating all people equally in morally relevant ways means respecting all people by respecting their health and human flourishing. So it's a people-centered approach, individual people. And global health governance is shared health governance then focuses on global health equity rather than a rational actor model based on self and national interests. And I've made this argument in a couple different articles that I've worked on, that just like setting up the picture and the sort of what the current landscape is in terms of global health inequalities and what's related to them, I've also said it's important to look at descriptively what the current governance structure looks like and what are the motivations behind it. And I've argued that the motivations behind it, the system is set up to represent individual nations' interests. And that's the way it was set up by contract, by treaty, and many international organizations. I've discussed the World Health Organization and other different organizations. And it's also very much a free market. So any individual foundation, and we know there's many foundations that are involved in global health governance, that enters the global health governance space, there are no duties or responsibilities or obligations that are laid out from a normative perspective in terms of what they can and can't do. and how their work may or may not be related to these inequalities. So it's a free market. And their interests, whether it be their shareholders or their board of directors or their particular mission, is really what governs what they do, as opposed to being governed by some broader set of duties and responsibilities. So that's sort of the gist of it. Okay, so in terms of health and global governance, why does justice matter? It matters because reducing health disparities requires social organization. And I'll just go through these very quickly, but in the form of redistribution of resources, related legislation, public policy, public regulation and oversight, and the creation of public goods. And there's some excellent work being done in all these different areas. Redistribution of resources is also a focus of the global justice literature. In particular, as I said, with a focus on poverty. And so how do we go about trying to turn this around in terms of redistributing resources to try to address this poverty that exists? And I'm talking about that, but in particular, addressing health disparities through redistribution of resources. And then legislation and public policy, and these other factors. So health and global governance should then place individual health and human flourishing at the center of health governance, as opposed to these other paradigms that may take other focal variables as the driving framework, and also opposed to national and self-interest. And so say that there's national actors, there's countries that act, but there's also lots of different institutions that act in global health, whether they be foundations or nonprofits or whatever. And so shared health governance and provincial globalism take that alternative perspective. And I've argued for some type of a overarching structure, like a global health constitution, that can coordinate this shared responsibility, because, as I said before, it's very much fragmented and decentralized and very much, in many ways, a free market. So redistribution of resources can occur in many different ways, between groups from wealthy to poor. This can be either globally or within a society, from the well to the sick, and also through generational transfers. And then there are different policy measures for doing that. And the policy measures differ from the global and the domestic space, because in the global space, of course, we don't have global government. So we don't have, even the UN system is not a government in that sense. It's governance, and so and there certainly isn't. Although there are kinds of coercive measures that can be employed, whether they're sanctions or other kinds of measures, they really don't have the government that we have at the domestic space, where we have the legitimacy of governments to use coercion and force. We don't have at the global level. So in terms of the health policy sector, I focus a great deal on the financing of healthcare, and specifically a type of financing of healthcare, which is health insurance. And of course, public provision of health services where markets fail to deliver, and provision of public health information, surveillance, and services. That's the public goods part, and the services where the market fails to deliver is something that obviously in an NHS system you know well. But in many developing countries, and certainly in many of the countries that were in the worst off health group, financing health services occurs through out-of-pocket payments. And the provision of public services where the markets fail to deliver is not occurring, and particularly with quality health care. So that's a health policy sector failure in that regard in terms of infrastructure. I won't go into the other policy sectors, but absolutely this focus on reducing poverty, which we see as a major issue. And then these sort of map onto the different factors that we discussed earlier. So this to say that global governance and domestic governance for health involves other sectors besides just the health sector. However, there are particular approaches within the health sector that can be taken much more effectively to actually address the health inequalities. But certainly other policy sectors are important. In terms of public regulation and oversight of private markets, again, this is something that may be taken for granted in an NHS type of a system, but there is a great deal of failure in terms of regulation and oversight of private markets. So in terms of the duties and responsibilities more specifically, this takes a functional approach. So duties are allocated based on the kinds of functions that different actors take. And then the sort of domestic space is one space, that both the public, whether it be government, or the private, whether it be nonprofit or other kinds of entities, at the domestic space, and then globally as well. And so at the state level, actors and institutions assume primary responsibility for creating social conditions within countries, fulfilling all individuals' opportunity to be healthy. And then the goal there is, as we talked originally about, is the shortfall between potential and actual health. And provincial globalism entails a consensus between the global values and goals and the domestic space. And that's so that the global actors and domestic actors can work in conjunction under the same set of values, as opposed to a system where they're operating under very different motivations. And we get what we have now, is the current system. So global actors and institutions play a supportive and facilitative role then, creating conditions in which societies can develop and flourish and promote health of their populations. And certainly if it is true that there's some causal action going on in terms of creating poverty that then creates poor health, then that would be a link to address. And broad-based approaches are needed as opposed to narrow technical approach. And this really gets into the sort of horizontal versus vertical approaches in global health. And there's a lot of work that's being done on that. And then the idea is to create a level playing field and address issues of affluence and power, as well as specific investments and redistribution and policy that's needed. And so state actors and institutions assume primary responsibility, and they take the effort to reduce the shortfall. And global responsibilities are in this macro social area, which relate to poverty and the other determinants or associations of health. And then within health, particularly 4 different areas. The first is generating and disseminating knowledge and information. This is the public goods aspect. And then empowerment or participation, so that the interests of those individuals who are represented by being in the worst off health group can be represented in these spaces. Technical assistance is critical in terms of financial aid. There's obviously, with such low levels of investment, there's obviously a great deal of additional financial aid that's necessary. So that's part of the redistribution of resources. We don't have enough money. These countries don't have enough money in the system. So more money is absolutely needed. However, it needs to be equitably distributed and efficiently distributed as well. And this framework takes very much takes a systems approach, so development of health systems in terms of financing and the technical assistance for the development of that. And then greater coordination and linkages so that this sort of fragmented free market, everyone for themselves approach is reined in some way by greater commitments across all the different actors to equity, health equity. So in terms of the first, so the first of these 4, these are sort of very well known and well studied areas of generating and disseminating knowledge and information. And one of the key things here is that we know how to prevent HIV and AIDS. We know how to prevent malaria. We know how to prevent TB. We know how to address it. And yet, why are these diseases and conditions so prevalent in areas where we have the information? So in other words, no new additional interventions are necessary. And they're available in other environments that have already addressed it. In the US, malaria was very prevalent many years ago, and it's basically been addressed. So it can be. The question is, how do you go about doing that? And what's the information that's already available? Why isn't it being distributed and used and employed in ways that can effectively address these conditions? And there may be new information and knowledge that's necessary. There's a lot of investment, for example, in a vaccine to prevent HIV and AIDS. But we also know how to prevent it. And then helping countries develop their own informational research capacity so they can have strong and robust surveillance systems themselves. So in my country, we have the Centers for Disease Control and Prevention, the CDC, which is a very robust infrastructure for surveilling the public's health and understanding the particular diseases and conditions that are prevalent, the incidence, and providing that information to even at the local level, all the way up to the HHS. And so in terms of technical assistance, these kinds of institutions providing the assistance and the financial aid to develop this infrastructure better in these kinds of environments. This is more of the participation and greater representation of individuals. And then finally, and I'm almost through with my slides here, I want to focus specifically on the health systems development, because again, this perspective, as opposed to other perspectives in global health, which tend to take a vertical approach, this focus on specific diseases and specific programs, this takes a health systems wide approach. So it's the development of the infrastructure itself. So, and the technical assistance that can be provided by global entities in developing equitable and efficient health financing, and again, the focus on insurance, training of medical and professional, public health professionals, regulation. Again, we take these for granted. These are actually critical infrastructural investments that are required for a health system to function well in terms of addressing the health needs of the population. And then in terms of the state's obligations, critical focus on an institutional framework. So, the whole plan for health, that the infrastructure that I just talked about is supported by the plan, and the focus on all the different aspects of the health sector, and particularly the health insurance system. Again, we see a great deal of financing being done out of pocket and in a regressive way, as opposed to a progressive way in which we have some sort of, lots of different models of health insurance. It's not just an NHS-based model. There's other kinds of approaches, social insurance funds, all different ways. But this infrastructure takes money, and it takes planning to set up, and in many cases it's just not there. And then quality, a focus on quality, and providing the access to health-related goods and services that, again, we saw those better off countries, people in those countries generally know there is certainly inequalities within those countries that I'm not looking at in this analysis, but certainly those countries on average have access to. And why shouldn't countries in the worst off group also have this kind of access? What is it? Is there some sort of reason that we think that should be the case? Maybe it is. Maybe it's just they're left off on their own, but that there are responsibilities to develop that. And so focusing on, again, these infrastructure investments in healthcare and public health, but that they be high quality so they actually are effective for the population. Okay, so just last slide. I'd argue that responding to the health inequalities requires a normative framework, a shift, paradigm shift. And that both international and national responses be rooted in ethical values, human flourishing, health equity, about health and its distribution. And that these principles can create these standards for the infrastructure to motivate and shape obligations and hold actors then responsible and accountable, because the accountability in the system isn't there. And so the question is that okay? Should we just have business as usual and argue that without this, business as usual, the same sort of trends and the same sort of dynamics that we're seeing will prevail, and that will not reduce that gap in health inequalities, and it will go unaddressed.